This image should be the first thing you think about when you ask yourself, what is decerebrate posturing? A person's arms and legs are extended or straight. Even though the term has the word posture in it, understand that it's actually a reflex. So if someone presents with decerebrate posturing, understand that they are not necessarily always in this position. They can have moments of relaxation, but of course it depends on each individual. Now back to talking about how it's a reflex. Well, a reflex normally occurs as a response to some sort of stimulus that evokes it. In the case of decerebrate posturing, it's a reflex that occurs when a noxious or painful stimulus is induced. Let's say you know someone or have a patient. They're lying down on their back, their arms are relaxed on their chest, and their knees are slightly bent. If I were to provide a painful stimulus, let's say putting deep, firm pressure into this person's upper trap muscle, so upper shoulder muscle, if this person does present with decerebrate posturing, what's going to happen as a result from me applying this firm, deep pressure is arm and leg extension. So what you see in this picture. This kind of posturing is only present when there has been damage to the brain, and severe damage while we're at it. So things like a stroke, think traumatic brain injury, tumors in the brain, raised intracranial pressure, among other reasons. Here's the thing though, not everyone who has had any of these potential causes will have decerebrate posturing. Only if there is damage to a specific area of the brain will decerebrate posturing possibly exist. So this is a lateral view of the brain. So we see the brainstem with the blue part or top part of the brainstem being the midbrain, the pink is the pons, and the purple is the medulla. With decerebrate posturing, the damage in the brain must occur below a certain structure within the midbrain. And this structure is called the red nucleus. So this is another view of the brain. And the image on the right is a cross-section of the midbrain showing you how the red nucleus looks like. Now the important part, to present with decerebrate posturing, damage to the brain must occur either at or below the level of the red nucleus in the brain, specifically between the superior and inferior colliculi. So if a person has had a stroke in which the area that's affected is at or below the level of the red nucleus, they can result in having decerebrate posturing. If a person has had a traumatic brain injury in which the area affected is at or below the level of the red nucleus, they can result in having decerebrate posturing. I think you get the point. The structure of the red nucleus itself isn't necessarily what is the most important. Instead, it's about the tracts that lie below the level of the red nucleus that matter with respect to decerebrate posturing. So here's an example. Let's say we are at the level of the brainstem. It's the midbrain at the level of the red nucleus. Let's say there's a tract that begins physically above the red nucleus. Now let's give an example of one that starts below, physically, the level of the red nucleus. Now if all is well, both tracts do the same job. They're going to send information from where they begin, down the brainstem, downstream to the body. But now, give an example. What happens if there's a lesion above the red nucleus? Well, as you can see, this lesion cuts straight through that longer tract, the one that begins above the red nucleus. So it interrupts information that's being sent via this longer tract. As a result, all that's left is the information coming from the tract that began physically below the level of the red nucleus. The same thing would happen if there's a lesion at the red nucleus. As you can see, that lesion still affects the longer tract, the one that begins physically above the red nucleus, and the one that's below it is not affected. Because the bottom one remains intact, it's purely just information that can be sent from this bottom tract. So with respect to decerebrate posturing, this is the tract that matters. This is the one that explains why there's a reflex of upper and lower extremity extension. Let's talk about the pathophysiology of it. There are actually two tracts, the vestibulospinal and the reticulospinal tracts. These both start, again, below the red nucleus. So if you look at this image, you'll see another tract. It's actually called the rubrospinal tract. This one begins at the level of the red nucleus. So just use it as a starting point, as a reminder for where the red nucleus is. So in this case, its function, the rubrospinal tract, it does not matter because remember, a lesion at or below the level of the rubrospinal tract where it begins, or the red nucleus, that's going to get disrupted anyways. But if you do want information about it, check out my other video on decorticate posturing. Let's talk about the vestibulospinal tract first. This tract has multiple functions. However, we are only going to talk about one of its functions because this is the one that really pertains to decerebrate posturing. So one of its functions is to maintain lower extremity extensor tone to assist with posture. Now let's give an example. Let's say I'm walking or I'm standing and someone accidentally runs into me, and as a result, I lose my balance. This is a tract that works as a reflex, and what it does is it helps my extensors of my legs work. That way I can avoid falling. The next tract is the reticulospinal tract, and this one is a little bit different. It helps to modulate reflexes. It has involvement with the arms and the legs. So it modulates into flexion as well as extension. So what makes this tract different is that it does not induce flexion. It does not induce extension, but instead it modulates how much extension and how much flexion is occurring for the sake of maintaining posture as well as balance. Let's put it all together and talk about the pathophysiology of decerebrate posturing. So let's say you pinch someone's upper trap muscle, and they have a lesion, of course, at or below the level of the red nucleus, and specifically between the superior and inferior colliculus, as I mentioned before. When you get pinched, there's a stimulus that comes from the periphery of the body, and it's going to send information up toward the brain. Well, the first tracks, as you can see in this image, that this information is going to run into is the vestibulospinal and reticulospinal tract. So this stimulus is going to initiate that reflex that's caused by activation of both of these tracts. I mentioned earlier that the reticulospinal tract does not create a reflex, and that is true. However, in the case of something that causes severe brain damage into which it can result in decerebrate posturing, these tracts almost act as a reflex. Now, when both of these tracts are stimulated, both of them work to extend the lower extremity, right? And that is the reason why we get lower extremity extension. And the reticulospinal tract involves the upper extremities. Now, although the tract inhibits and modulates into flexion as well as extension, the one that overrides the other is extension, and that's why we see the arms extended. Now, normally this stuff would not happen, and that's because the upper cerebral aspects of our brain, they would normally send information down to help modulate these reflexes. However, as we saw, if there is a lesion somewhere in the brain, you cannot send information down from levels that are higher physically. So it's essentially because the brain cannot send any information down because there's a lesion disrupting that information that this reflex of arms extended and legs extended continues to present. Let's bring this all together. Decerebrate posturing is due to a lesion or a disruption in the brain, specifically at or below the level of the red nucleus. The red nucleus is a structure within the midbrain of our brainstem, and this is going to cause upper and lower extremity extension due to the lack of inhibition coming from the brain at areas physically higher than what's at the red nucleus. And it does not inhibit the vestibulospinal or the reticulospinal tracts. If someone presents with decerebrate posturing, this suggests severe brain damage. You are not just going to see someone who's walking and talking about and have decerebrate posturing. Someone who demonstrates this is unable to walk. They're unable to talk. They're unable to respond to stimuli, and they're in a comatose state. So this is why when you look at images of decerebrate posturing, it is always going to be a person in supine instead of sitting or standing. If you're studying for the NPTE, check out our courses at sptwithme.com. Check out these references for more information.